Thank you, Khanna. And I'll present two failures which were ultimately fatal, and both are related to uh, thoracic endovascular repair. So the first one was a 46-year-old lady who had a long prior history. She's probably got some kind of a connective tissue disorder, and in 2000 she had undergone a Bentall surgery for severe aortic regurgitation and dilated aortic root. And then in 2012 she had a type B dissection, and a TEVAR was done, and a single graft was placed covering the left subclavian artery. Now, both of these were elsewhere, and 5 years after the second procedure, she presented to us with a contained rupture of the aortic false lumen. So this was the CT angiogram at that time, and you can see that the surgical graft is in the ascending aorta. Then there is some aneurysmal dilatation of the distal ascending and the arch. Then there is this endograft in the distal arch and upper descending aorta. And then there is this huge false lumen and a very narrow true lumen distal to that, going all the way to the iliac arteries. And this is an axial image. You can see how big the false lumen is. It's 10 centimeters by 8.4, and the true lumen is a very tiny sliver on the medial aspect. And the true lumen was very small in the abdominal aorta as well, and the angiogram here shows the true lumen almost obliterated. And only the left renal artery and the superior mesenteric artery came off the true lumen. The right renal and the celiac came off the false lumen. And the lower down, the true lumen extended into the right iliacs, and the left iliac system was fed by the false lumen. So very difficult situation, and here's a patient who was very acutely sick and very difficult anatomy to deal with. And she had this type 3 kind of arch with a sharp bend there, and we don't have subclavian access on the left side. So we thought we could try and make a perforation in the graft and try to come through that perforation to get an access from above. So this is a brachial angiogram, but then we actually punctured the left subclavian artery, supraclavicular puncture, and tried to get a Brockenbrough needle to break through this. But because of this angulation, it just kept slipping down. And we didn't have RF ablation with us. So finally, we used a left carotid access. And this was a very difficult access with all these sharp bends. So we had a through and through wire from the carotid to the femoral to stabilize a 9 French sheath. And that straightened out a little bit and then gave us some access from above. And this is a false lumen angiogram, which shows the celiac artery was nearly occluded at its origin. But when you engage it, you can see a flow going through. So the true lumen in the distal thoracic aorta was very small and the false was very big. So initially we put a extension graft to the existing graft up to the celiac level and ballooned it and opened out. Basically, we tore the intimal flap between the true and the false and expanded the graft. And then we extended in the visceral segment with a fenestrated graft, which we made. We made 4 fenestrations, SMA, celiac at the same level, and the 2 renals lower down at the same level. And then we deployed this graft, and we managed to cannulate the superior mesenteric artery and the 2 renal arteries, and stented into those vessels. And this is the superior mesenteric angiogram. When you inject contrast into the superior mesenteric, it fills the celiac artery later on, and you can see the celiac artery filling at the back a few frames later. So we were not able to cannulate the celiac artery, and then we decided, okay, the celiac territory is anyhow getting supply from the superior mesenteric territory, and its mouth is very narrow, so let's ignore it. And this, if you remember earlier on, the celiac looked like this on the right, and this is what we are seeing on the left. And no contrast is flowing into the sac, at least in this angiogram. So we decided, make things simple, forget about the celiac, and we put a 8 mm ASD device and closed the celiac fenestration, and then continued with the repair. We put a bifurcated graft lower down, extended it into the iliacs, and on the left iliac side, we put kissing stents to preserve flow into the internal iliac artery. So this was at the end. We had some gutter leaks from the left side, but we thought that will settle down. And this itself had taken a lot of time. And she was extubated only the next morning. But within a few hours, she started saying she's having severe back pain, and her hemoglobin dropped to 4.5 grams. And we gave multiple transfusions, took her back for an angiogram. Couldn't find any type 1 or 3 leaks, but we kept seeing this false lumen opacifying. So we thought maybe it's got something to do with the overlaps. So we put some more grafts in the overlaps of the previous endografts. And we even jailed the left internal iliac with a single graft from the common to the external, thinking that maybe it's the gutter leak. But she kept bleeding and kept going downhill. Her abdomen became tense. There was a lot of blood that we could aspirate from the abdomen, and did yet another angiogram. And you can see this false lumen is still filling, but we can't really, at least at that time, we couldn't figure out how it was filling. But this is what was the reason. That celiac artery was actually still flowing backwards into the false lumen. And the superior mesenteric was supplying blood to it, and it was coming out of the celiac artery. And we didn't realize it at that time. And by the time we realized it was too late. So the lesson we learned from this case was that if you fail to cannulate a fenestration, through a fenestration, reach the target artery, then you need to occlude both the fenestration and the target artery. If you leave that target artery open, you will get a reverse type 2 kind of endoleak, which in this kind of situation was quite proved fatal.
Dr. Joseph, please, sorry to interrupt, sir. Kindly show the concluding slides. We have short of time. Dr. Veeth is waiting for his oration.
Yeah, this is the last slide. And if you have an emergency case like this, you can simplify the procedure by just plugging the celiac artery right in the start and just save the superior mesenteric artery. And the last mistake probably was that we balloon dilated the endograft in the true lumen to expand it. And that can weaken the aortic wall and cause false lumen rupture. But in this case, there was already a contained rupture. So, but this might have added to it. So I'll stop at this point, and in the interest of time, although there is another case, but similar to this. So thank you for your attention.
Thank you, Dr. George. It was a wonderful case and very good learning experience. I think in the paucity of time, we have to go for another lecture.